Welcome everyone to today's TASC 90 webinar, our quarterly educational and technical assistance series for the National Rural Hospital Flexibility Program. And today we're focusing on population health, and that'll be our topic following an update from TASC and from the Federal Office of Rural Health Policy, and also an update from the Flex Monitoring team. All of the slides and materials are available as downloads on the left-hand side of your webinar screen, and we have some helpful links as well. And you can put questions in the chat box, or at the time of questions after each session, press star 2 to unmute your line. And I'll start off with an update from TASC, and with the Technical Assistance Service Center for the past few months, we've been working on the Flex Program Fundamental Guides, and this was previously known as the Flex Coordinator Manual. These are actually going out in the mail, I believe today, and the 2017 version of the Fundamental Guide is online at the TASC website, and it's easy navigation on the website, and all of the key areas have been updated. And these are great guides to have as reference on the Flex program and regulations and resources, and especially important to share with new members of your teams at your state Flex programs. We also have updated the state Flex profiles for 2017, and those are also accessed on the website, and you can search by state, and it's a quick way to find contact information for State Office of Rural Health and Flex program coordinators in each state. And then there's a synopsis of what that state is doing in each of the core areas, and it's a great way to also search for information on a specific topic, community paramedic, and you can enter that term, and within our search engine target, the TASC page, and it will search profiles that are doing activities in that area. We also have been doing the virtual knowledge group webinars, and the next one will be March 6th. On Flex grant and contract management. And these webinars are built to be interactive with some polling and the questions, and features a couple states sharing best practices. And then we are working with the Federal Office of Rural Health Policy and Flex Monitoring team on being able to use your PIMS data, being able to collect it in an easier way through a collection tool. And then also, now that Flex Monitoring team has been able to analyze first-year data, and going forward with the new PIMS questions, how to build that into your work plan tracking. So that data collection tool will be out soon, as well as a work plan, a template tool that can be used for a new template for the NCC coming out in March. We are planning for the next Flex program workshop in Duluth. That will be April 11th through 13th. And if you would like to attend or have someone starting in Flex work soon, please contact Bridget Hart here at TASC. And finally, we've been doing site visits and of course, planning for the 2017 Flex program reverse site visit. In that registration and information about the hotel block in Bethesda will be up soon. So if you have questions about that, you can contact TASC if you need details before the registration is open. So any questions from TASC? Well, we'll move on to the Critical Access Hospital Regulatory Update and Federal Office of Rural Health Policy Update from Wakina Scott and Sarah Young. And the document that is showing was provided by F4HP, some
Yes.
policy
Hi,
updates.
this is Joaquin, everyone. Thank you. Just a couple of updates. What I'm doing different for this particular update is providing you with a document that has more information in it versus some of the slides that we have used in the past. So hopefully you will find this to be more helpful in providing some of that information to you and being able to access more information via the links that are in these summaries. So the first one is the cardiac care episode payment model, or what they're calling the care coordination episode payment model, similar to what the comprehensive care for joint replacement model did, which was passed this year, which started this year. This model that CMS finalized in December and published is looking at trying to better coordinate care related to cardiac rehabilitation and coronary artery bypass grafts, as well as the acute myocardial infarction. So they're looking to try to, again, better coordinate care under this particular model. And one of the things we noted was that, yes, critical access hospitals are exempted again from being able to, or excluded rather, from participating in this model. However, they can actually participate as on the post-acute care side to provide those services after discharge for patients. So we're actually tracking this. We've been asking, our providers, critical access hospitals, how has this been going under the current CJR model as far as CAS receiving referrals to their swing beds, particularly for patients that live in rural communities. And so we'll be interested in seeing how that collaboration continues under this new proposed model that CMS finalizes. Whether or not there will be any changes to this particular proposed model given the new administration, we're still waiting to see, but our understanding is that as of now, this particular model has been finalized, and we have not heard any more as far as whether CMS will put a hold on actually implementing this particular regulation or move forward with it. So more to come for that, but I think it is something that to note for critical access hospitals. The other thing I wanted to note was that the March 8th deadline for implementing what CMS is calling their MOON, or their Medicare Outpatient Observation Notice. That deadline is quickly approaching, March 8th. And again, as a reminder, this is a notice that critical access hospitals have to issue within 36 hours of the start of observation services or sooner if the beneficiary is going to be transferred, discharged, or admitted as an inpatient. As you can see from the summary, you can access the links to the actual notice as well as instructions for implementing or providing this observation notice to beneficiaries. And the last policy or regulation that I wanted to highlight for you, not necessarily health related, but certainly can be helpful in terms of providing access to health services, is this recent Office of Inspector General final rule related to the anti-kickback statute. So really what I wanted to highlight is that in this final rule, what they're doing is easing the ability for providers to be able to offer free or discounted transportation services for healthcare without basically a safe harbor from the anti-kickback statute, so that they can provide such service. And this really would include all entities when it says under the rule federal health care programs, the ranging service. So this would include you know, your hospitals, your PPS hospitals, your critical access hospitals, FQACs and RACs, if they're able to provide such transportation service for beneficiaries, they can do that at a free or discounted rate. And just also for what I also wanted to note is that for rural patients, OIG has set the limit for up to 50 miles for patients to be transported to and from medical services. So definitely one that we're encouraging providers to look closely at, and one of the things that we'll be looking at to see if over time if this can be helpful in terms of looking at some of the transportation concerns that we're aware of in rural communities and accessing and being able to access necessary medical appointments. So I'll stop there and see if there are any questions.
Thanks, Wakina. It's star 2 to unmute. If you have any questions for Wakina on the policy update or regulatory update. Yeah, thank you, Wakina. And
You're
Sarah,
welcome.
do you have some updates?
Excuse me, Sally, was that, I don't have the agenda in front of me, was that us?
I'm good to see if Sarah Young has any
Oh,
updates.
sorry, I couldn't hear.
That's okay. You're fine.
I missed it too, John. This is Sarah Young. Thank you for that update, Wakina, and I hope everyone also noticed on the top of Wakina's handout the HRSA rural policy email address, which is always a tool you can use to reach out to Wakina and the policy team if you have policy questions. I just have a couple of brief Flex program updates. As I'm sure everyone knows by now, I'm going to remind you again that any carryover requests need to be into EHB by March 1st at the very latest, and we're always happy to see them sooner. And I do want to reiterate that any requests that are after March 1st will be rejected for being too late. And we're on track to have the non-competing continuation instructions come out the week of March 20th. And just like last year, that will be pushed out and resubmitted in EHB. And thank you again to Tracy and Caleb and Sally and the rest of the folks at TASC for your help on that and on developing the tools and templates that are going to go along with that. And I did want to just give another shout out to the TASC team for updating the Flex Fundamentals book. That's a great resource for all of us. And the Flex Program State Profiles. I frequently find myself referring people who want to know more about what kinds of Flex, non-Flex people who are interested in what's going on in their state, to those profiles pages, and they're also a really great way for Flex coordinators to find out what your peers are doing and get ideas from other states. So please use those, and thank you for sharing information so TASC could update them. A couple of other broader comments I want to share. One, big thanks to Marcy in Colorado for sharing a recent story she heard from a CAW about a unexpected consequence of one of their referral hospital partners participating in one of the CMS bundled payment programs. And when you guys encounter stories like that from CAWs and other folks that you're working with, please do let us know, because We want to know about what challenges the rural hospitals and rural healthcare providers are encountering with some of these demonstrations and new payment programs, and it's really helpful for Joaquina and her team to hear about real examples that demonstrate the rural challenges. So thank you for sharing that, Marcy, and everyone else. Just want to let you know that we're always interested in that kind of report. You can either tell your project officer or you can reach out to me or Joaquina directly. And if you just don't get enough policy updates from Joaquina on these TASC 90 calls, you can always sign up for the FRHP announcements emails that come out about every week that includes policy updates as well. And that was all I have. If there's any questions, I see that Nancy Joe did ask in the chat box what's the expected turnaround time on the notice of award for carryover requests. And it does vary a bit, Nancy. We try to get it turned around in a couple of weeks, but it's going to depend sometimes on if we have additional questions or complications. If you have a time issue, definitely reach out to your project officer and we'll try to work with you. But it does take us several weeks to review and finalize those.
Thank you, Sarah. Any other questions regarding Flex grant management or overall Flex program from FRHP?
And you can press *2 or type them in the chat box if you have questions.
Thank you, Sarah, and thank you, Joaquina, again for the updates. Now, moving on to Flex monitoring team, John Gale will provide some updates from Flex monitoring team, as well as then move into our topic today, which is population health. And John will be highlighting some FMT tools to monitor population health performance. And John joins us from the Maine Rural Health Research Center in Portland, Maine, which is quite snowy after last weekend's storm. John, so glad you could join us.
Why, thank you. In fact, it is now snowing as we speak again. We're getting our 5th of 9 storms in the last week and a half. So.
Oh, gosh.
But it's why we live in Maine. So thank you, everyone. I will do a quick overview of some of the ongoing Flex monitoring team activities and then talk a bit about our tools that can be used around population health. So in terms of our normal work products from the University of North Carolina, we're in the process of refreshing the COMPASS data in the next week or two. This will include finalizing some of the new financial information and community data. I mean, part of what is the challenge for us is reconciling complex data pieces in quality, community, and finance, and then being able to pull them up and do the comparison to individual hospitals across against states, state averages and state performance or peer group performances. So, and that has been worked out pretty well, I think, for the financial side. It's a bit more of a challenge for the community piece, and we're working on that. So that'll be updated a bit shortly. I also understand that the folks at North Carolina are finalizing their state median reports for finance and will be distributing those by their normal means, which I think the hospitals find quite useful. From Minnesota, they've released the state reports for hospital compare and HCAHPS, and they're also I've released 2 national data summaries for both of those data sets, so that's where they're moving. On the main side, we have a couple of different projects that are underway in addition to providing the community data for Compass. We are doing a lot of evaluation work at the moment, so we're currently involved in an evaluation of some of the innovative models and really working hard with the states, and I do appreciate the folks from state flex programs are willing to work with us. And I think that's going to be helpful in terms of a number of different areas, understanding how states can innovate and what information and how that information might be used by others in areas related to practice transformation, use of telehealth technology and for Project Echo or direct service delivery, and some quality measurement and improvement in ACOs and other practice transformation activities. I think the other part of it is really looking at, as we monitor and track performance, is getting some, I think, real on-the-ground feedback from the states on the whole complicated issue of identifying and measures and tracking outcomes. This is a difficult challenge, and one I think we've all wrestled with in Flex, and so we'll be using that information to help inform some of the thinking around outcome measurement. We're also evaluating EMS. The EMS assessments that were being done in the first, and in some cases the second year of the grant process, to learn what kind of tools what tools are available, and how those tools may be used by other states. So EMS, if you all remember, if you were to take on an EMS activity in the current funding cycle, you needed to do an assessment. So we're really looking at some of the outcomes and results of those assessments to understand what the needs are. And both of those projects will see policy briefs plus internal memos to the office this late spring, early summer. So that being said, I think that's the bulk of our work. We're also working with Caleb and Sarah on the PIMS data tools, and we've got an analysis and framework of the current PIMS data that we're working on now, and we'll be sending that to the office, and with a real thought about how we could use PIMS as part of the overall measurement and strategy. PIMS is complex, and there are, I think, ways that it can be better incorporated into state planning, and we'll be working on those activities. Now I'm going to jump in very quickly and not spend too much time, because I know there's a lot to do today, on some tools that we've developed to monitor population health performance. I won't spend a lot of time on population health because I think many of you have seen some of the slides and presentations we've done, and I think have a pretty good handle on it. So the real question then becomes in how we measure it. And just as a refresher, I always like to use this slide because we get a lot of pushback from hospitals when you talk about population health, and the traditional response is, oh my gosh, we have enough on our plates to make payroll and see patients and do all the things that we need to do, and now you're going to tell us we're responsible for the health of our communities and our population, and we have to address social determinants for health and all those complicated issues. And I think the answer to that question is yes, we do. But we don't expect them to fix everything, but think about the role that the hospital can play in addressing community needs, and to think a little more broadly about population health. So this comes from the Health Research and Education Trust of the American Hospital Association. So it's just not those of us from the academic world or from the policy world suggesting that hospitals need to take this role. This really comes from the hospital industry. And it really is moving from an acute care provider to, and solely the delivery of medical care, to playing a role, and that role can be defined by the needs of the community and the resources available on community issues around, say, substance use, domestic violence. One of the common problems we're hearing about all the time is around opioid use, and hospitals can play a role in that. Critical health issues and services that are needed, oral health, mental health, obesity, and there are examples of CAHs that are doing good work in all of those areas. Looking at equity, what are the barriers to access in a community and health disparities, and can they help to alleviate some of and overcome some of those barriers? System issues. So what does the public health infrastructure look like? Public health being an important part of the system, but not always available in rural communities. And can the hospital pick up some of that role around immunizations, tracking communicative diseases, and working with the public health? And finally, in identifying the role of the community in the process. How do you engage people? How do you bring them into the mix? How do you work with them to reduce risky behaviors? So it's just a quick summary of what I think is important for hospitals to remember. And so as part of this process, we developed some community measures that through an expert panel, and we were really excited to pull some of the experts together that we did. We had Tim Size, whom many of you, if not all of you, probably know. We had a fellow named Kevin Barnett, who has done a lot of the lead work on community benefit through the Public Health Institute. We had Paul Haddis from Tufts in Boston, and we had some rural hospital providers in this mix. And so we created and identified some community measures that our panel thought was really useful for measuring a range of community and population health activities. It sort of provides a contextual description for the socioeconomic and environmental health challenges that many communities, CHs, face. And it also provides some data to monitor and provide a snapshot of where hospitals are. So we're testing and refining them. We are loading them and doing some updates to expand that the data in Compass, and we're working quickly to get that fully up and running. Let me see how to do this. There we go. So some of the measures: charity care and bad debt, a clear, common measure of where hospitals are in terms of serving vulnerable populations. And so that's a big part of what we're looking at. And so often hospitals, people aren't really clear about the difference between the two. And so we're tracking both of those measures from the cost reports. And then on the other side, we've identified through secondary data sources a variety of health improvement, essential health service, and community benefit measures that can look at the health of a community, provide some context, and provide us a way of looking at what the vulnerabilities of rural communities might be in where CHs are located. So we're doing this to measure the community context. We've got socioeconomic factors, environmental factors, outcomes, health behaviors, and access to clinical services. Charity care, very quickly, it's charity and discounted care as a % of adjusted revenue, which is the standard way of tracking this, and bad debt. And it looks at from the perspective of the ACA and the Internal Revenue Service requirements around community accountability. It's an important part of how hospitals respond to community needs. Under the essential services, these are less about a percentage and more about, it's a yes or no question about our hospitals doing this. So what are they providing for wellness and prevention services? Are they engaged in tobacco treatment, dental services, indigent care clinics, urgent care, primary care, substance use, mental health, and immunizations? We also have some measures from the AHA survey, which is really looks at how they're thinking about diversity planning, do they have a diversity strategy or plan? We know that rural communities are becoming more diverse, and we're seeing migrant populations of Hispanic populations in some communities, and different ethnic groups that are settling in the U.S. So do they have the capacity to deal with cultural and linguistic diversity issues? And how does this fit into their strategic plan? Then the community needs. So we've looked at a variety of socioeconomic factors, and we've tried to really narrow this down. So we're looking at graduation rates, unemployment, for the percent of the population over 16 that are unemployed but seeking work, the percentage of children under 18 in poverty. Also looking at environmental issues. Do they have recreational facilities? We know obesity and access to recreational services can be a real challenge in rural communities. Do they have access to these services? What about food access? We know many rural communities are food deserts, and they have poor access to healthy and affordable healthy foods. So what does that look like in terms of their proximity of folks to grocery stores, or whether or not they have access? Health outcomes, and these come from the county health rankings. Now, there are issues with county health rankings, but I think it's the best that we have. But they do provide some indicators. What are the premature death rates? The years of potential life lost before 75 years of age? What are the percents of the population that report they're in poor or fair health? How many children, what is the percentage of low birth weight live births? Health behaviors, adult smoking, adult obesity, the extent of physical inactivity, excessive binge drinking, which is both binge and heavy drinking, and the definition of what those are pretty scary. Binge drinking being 5 or more drinks for an adult male within an hour or two, and heavy drinking is having those binge drinking episodes at least 4 or 5 times a month. So it's a pretty serious measure. Other health behaviors, motor vehicle crash rates, we know that's a big problem in rural communities, STDs, teen birth rates, and then we have some measures of access to care. So primary care physician population ratios, dentistry, what percentage of the population is under 65 is uninsured, to what extent are women Medicare enrollees receiving mammograms, diabetic screening, the percent of diabetic Medicare enrollees that receive HbA1cs. What are the measures of preventable hospital stays? Are we making a difference? Percent of individuals without a personal doctor, and those that haven't seen a doctor in the past 12 months due to cost. So I'm down to a couple of slides, and I'll finish up. So in terms of thinking about how to use these measures, and they'll be able to provide, and much like the financial measures through Compass, you'll be able to look at a hospital administrator can look at his or her hospital, then also look at de-identified data for hospitals and their peer groups or their states. So we can look at where a hospital might be in terms of charity care and bad debt issues. That varies both in terms of the hospital's charity care and financial assistance policies, but also with economic conditions. So some of the things they might do is really look at where those patients are, where their patient base is in terms of their incomes around their eligibility criteria and what they might do about that. Is a higher rate of bad debt really people who aren't willing to pay, or is it a question of the policies and whether they should look at those? We also want to look at patients with high out-of-pocket health costs. We know that many people are insured, but if they have $5,000, $10,000 out-of-pocket for the personal or family costs, they're functionally uninsured. So what does that tell us about what policies need to be undertaken? Can they improve the screening process? Can they revise billing systems to capture and manage charity care at different stages of the billing process? But a process to think about looking at that issue. Another category of low-income patients that otherwise qualify for charity care but don't. Maybe think about revising the application process, reaching out, simplifying that process. So where your hospital falls in terms of others and provides clues and questions to ask. So essential community services, we're not saying that a hospital in CH has to provide every essential service, but it is helpful if they can work with local providers to figure out the best way to use scarce resources, offer some of those services that may not be available, but work as a whole and across community organizations and providers to address service gaps. Health outcomes measures. This is, I think, one of the important areas, looking at where an individual hospital might be in terms of these measures and understanding why. Now, if they're a not-for-profit hospital, they've already had to do a needs assessment, but public facilities, county, municipally owned, don't have to do that. And so there are reasons, they can look at the reasons behind poor performance. Maybe they want to interview community members, inventory local resources, think about the partners they might engage, and think about what the community needs are and what role they can play. And that's really it, unless if there are any questions. If not, thank you.
Thank you, John. And that's great to have the background on how the data measures in the community area of Compass were selected and how the hospitals may begin to do that analysis and compare to their peer groups. And from Flex programs to be able to look at overall hospitals and utilize this information with developing their population health activities within the Flex grant and may augment their statewide population health needs assessments.
Thanks, Ellie. And I think it provides another tool. I know you'll be talking about your own data portal, and there are two sets of information, and it's always important to triangulate. And so I think both portals have value that can be used in this space. Thanks.
Okay, great. And Sarah provided a link there to the main Flex monitoring team website for all of the publications and briefs that John described at the beginning of the update. Now we'll move into the population health portal features and the uses for state Flex programs. And the Population Health Portal is hosted by the National Rural Health Resource Center under the TASC program, which is part of the cooperative agreement we have with the Federal Office of Rural Health Policy to support the state Flex grantees, the Small Rural Hospital Improvement Program grantees, as well as small rural hospital transitions. And the portal is designed for hospitals, networks, and also state Flex coordinators. In today's objectives is I'll point out some of the features of the Population Health Portal and show how Flex programs can leverage the resources assessment and the data scenarios to support CAHs and develop relevant Flex program activities within the population health core area. And we have a new feature on the portal for using claims data and supports hospitals' ability to use that information to align it with what they're gathering from their electronic health record or community health needs assessment. So this tool for the claims data is more to make you all aware of it so you can share that with hospitals, especially those who are independent and may not have data analysts readily available or even be part of a network that provides data analytics for their information. So Bridget had shared the pictures of our speakers, and we just heard from John. And following my update on the portal, we'll hear from David Mark from the College of St. Scholastica. And this is the landing page of the Population Health Portal. It's on the center's program links, and we first launched it last December. And again, the goal is to provide resources and a starting point for hospitals and networks navigating the journey towards population health. And as a FLEX coordinator, you can use the Population Health Portal. Is that first off, there is a readiness assessment, which I'll walk through, and this is designed for hospitals or rural health networks to complete. There's a resource library specific to population health in a variety of categories, with primarily federal resources that are in resources applicable to small rural providers. And then we have 9 different data scenarios with publicly available data, and the scenarios are specific around population health analysis. And then we've added the claims tutorial through a YouTube video, and David will be demonstrating that today. Population health readiness assessment, and the first step. And this allows rural hospitals and networks to look at how they are prepared for population health, and then from the results, there will be targeted resources that are unique to their needs or their strengths for transitioning towards population health. And there's only 21 questions. They are outlined within our Performance Excellence Framework that we have previously developed for critical access hospital success, and also through our initial population health guide. And the framework includes looking at assets and leadership, strategic planning, patients, partners, and communities, data collection, operations, workforce and culture, and finally outcomes and impact. And we advise hospitals or networks completing this to perhaps not just one person or leader to do it, but to have a team, put some thought behind, how do they feel in terms of population health, that not just their CEO personally, are they, for instance, aware of value-based reimbursement models, but the leadership of that network or hospital, so that team might include director of nursing, marketing, the CFO, as well as the CEO. And after completing the assessment, the hospital or network receives immediate results on their screen, and in this case, the score was 59, and that is out of 105 possible points. And it gives them a sense of, where they are, and then also then there are resources that are targeted to the responses to the questions. If the hospital scored themselves low in leadership's understanding of population health, there are going to be 2 or 3 key resources in the leadership area targeted towards them, as well as the next area that maybe they were only scoring a 3 or 2 on average out of a 5-point scale. So they also receive this information in an email, so they can save it, print it out, and contact us for additional information as needed. And with FLEX programs, how we're envisioning that you all could utilize the readiness assessment is asking CHs in your state to complete the assessment and email you a copy of their scores, or ask them to send you an email allowing the center to release their scores to you. And actually, we're working with one state flex program where they're truly building this as part of their population health needs assessment. So the hospitals are agreeing to all complete the assessment and allowing us to roll that up and share that with the state flex program. So this gives you an ability, if you have the scores for a group of your hospitals, that you could identify areas for technical assistance, education, collaboration, and sharing of best practices within your state. You may find across your hospitals that data collection, data analytics was scored quite low, or that it's more the workforce and cultural understanding of population health. So this can be, again, augmented with data from Compass, as well as your the CHNAs that your hospitals are doing or that your state office or flex program have assisted those hospitals with doing that needs assessments or focus groups, as well as public health data. So it's kind of, one more piece of information to get that statewide assessment. And the resource library has numerous tools, including documents, webinars, and other websites to help the hospitals get motivated, get informed, or get going on population health. And again, these are organized by the 7 areas of the performance excellence framework. The data scenarios were created, and there are 9 scenarios, and there are 4 publicly available data sets. They include Hospital Compare, Dartmouth Atlas, which looks at Medicare spending, community health status indicators, including the county health rankings, and U.S. Census data. And there are filters that allow you, which I'll demo in a minute here, to filter it by state or by hospital type, such as critical access hospitals, a specific county, or different measures. And the scenarios were designed to answer questions that CHs or rural healthcare providers or states might have about healthcare issues within their state, county, or hospital. And it does a basic analysis combining these multiple data sets with the filters to allow you to, in one glance, kind of handle these huge amounts of data sets that are available for one hospital or one county or for your state. And then they can all be downloaded into Excel for further analysis. And some of the scenarios are specific to MB-QIP measures within, but the thing to remember, they are related to the MB-QIP measures, but this is hospital compare data because this is publicly available data. So it does not include raw data that is available through MB-QIP. And the updated data is changed in these data sets annually, not necessarily at a quarterly basis, which does happen for hospital compare, but not necessarily even annually for the health status indicators. The first one I just selected was the emergency department access. This scenario is built around the CH measure for MB-QIP in the outpatient area. And there's growing emphasis on adopting interventions that have proven effective for decreasing emergency department wait time and crowding. And the purpose of this analysis is to identify if there's an association between timely and effective care measures, such as looking at do hospitals that have greater waiting times also have a higher percentage of patients that leave the ED before being seen because they've waited so long? Or looking at the wait time and then those that are admitted to the ED or admitted to inpatient. And this scenario uses hospital compare data from 2016. And within the portal, if I clicked view the data for this scenario on emergency department access, on the one here on the screen, I selected the state of Kansas, and the hospital type is critical access hospital. And then the efficiency measure selected was ED1B. And then you'd hit apply, and this pulled up part of the hospitals in Kansas, not all of them, because there are so many, it's more than one screen. And then there's the, of course, county and the hospital name. These are all CAHs. And it does include the ownership. And then the efficiency measure name. And then the score and the denominator. And the score is the amount of time or average number of minutes spent in the ED. So the first one had Seward County had 143, and here in this score, a lower measure, lower amount of minutes in the ED is better. So we're seeing all of the ones up here are over an hour and a half to 2 hour waiting time, and then the denominator is sample size. Now also in this scenario, you can choose other measures, and those could include the OP20, OP22, so the amount of time they spent before they were seen, and again, a lower value would be desired, or the percentage of patients who left the ED. So you could look at all three. Given the space here, I didn't put all three on this screen, but it allows you to look at all three of those, which are MD-equipped measures, and look at that specific, how many of the hospitals are struggling with this issue, and help align activities within that area. The second one here is the socioeconomic status and well-being, and this was a new scenario we just added in January. And this looks at the connection between socioeconomic status and health status, as John was just discussing. And this is the landing page, which gives some background on why we selected the scenario and what it will look at. And this one is exploring health-related outcomes, including diabetes rates, premature mortality rates, and then also healthcare costs, preventable hospital stays, poor mental health days in relationship to socioeconomic measures such as household income, food insecurity, and race. And this information is from the county health rankings, as well as the Dartmouth Atlas for the Medicare costs. And this scenario, and Bridget, you might need to make this one appear as large as possible, please, so people can read it. The filters go down to the county level as well as state. In this case, this is not hospital-specific data. It starts with income inequality, median household income, percent of residential segregation between black and white, and diabetes, food insecurity, limited access to healthy foods, and mortality rates, and then moves into the Medicare costs and preventable hospital stays. And just in these counties selected in Arkansas, it's ranging from 78 in Clay County as high as 119 in Bradley County, preventable hospital stays, and then the total Medicare reimbursement per beneficiary per year, and they're all quite close, but going over it also looks at hospital and skilled nursing reimbursement, physician reimbursement, outpatient facility reimbursements, home health, hospice, and finally medical, durable medical equipment reimbursement. And then the third scenario demoing out of the 9 is another new one we've added, looking at uninsured rates, behavior, and mental health. And mental health being a leading cause of disability in the United States, and looking at those who have insurance are more likely to use types of mental health services, and thereby trying to prevent suicide and poor mental health days. Also looking at disparities in the socioeconomic factors. We brought together information from county health rankings. And again, this is just, an easy way to not have to pull up each county, but to look at all the counties and being able to search by county for those with critical access hospitals in your state to look at mental health issues. And we're seeing more and more integration of primary care and mental health services as there are care coordination models within patient-centered medical homes or Medicaid innovation models and other accountable care value-based models. And also even in the F4HP network programs, many of the networks, we're finding over half of them are focused on care coordination, and such a majority of those with chronic health conditions also have a mental health condition. That's we're thinking more and more that as hospitals are beginning to integrate their care, needing to learn more about this, as well as those presenting with mental health conditions in their emergency department. And a few states are focusing on mental health integration within the population health core area flex, including North Carolina and Montana. So this screenshot is for the state of Texas, looking at the uninsured rates. And the other feature on the data tool is you can hover over the column heading, and it gives you a definition of the data, but also allows you to sort for that specific area. So I could search or sort by county alphabetically, or in this screenshot, I sorted by percent uninsured, with the highest one here is 40% of the residents were uninsured in this county. It gives the median household income, unemployment, excessive drinking, drug overdose deaths, and then teen births and poor mental health days. And this was ranging from 4 in a few counties as low as 2.9. And then the last one, and then turn this over to David, was can you explain why we asked the College of St. Scholastic, our subject matter expert in health information management, who has designed the background of the data and helped create the databases to allow these filters and sorts and to put the data to use. And we were hearing through our work, especially with the summits that we had last year on financial leadership and rural provider engagement in value-based models, that there was a need for data analytics within rural hospitals and networks. We talked with the College of St. Scholastica, and is there a way you could help demonstrate this information if a hospital is receiving some Medicaid data, or maybe they're just getting into different models of Medicare value-based payment models, that they're receiving information and how can they use that at the local level. So they've created a video and some tools that David will walk through. And I see there's a question about having the benchmark to compare the state data. And that's a great suggestion, something we've talked about internally as well, to be able to, not only say the lower numbers better, but to calculate an average for your state or the hospitals you've selected. And I think you're probably talking about the national benchmarks as well. And David may be able to help in terms of, if you move the information into an Excel, definitely there's ways to look at the medians and means within your own state.
Yeah, Sally, I'll just add to that too, that that is something that there are some demonstrations in some of the video tutorials on ways of working with the data and exporting it out to actually calculate those benchmarks yourself. Like you already said, looking at the median values depending on the measure, and just also looking at the national benchmarks as well. So, yeah.
But it's definitely on our list, Jennifer, within the tool that we built to be able to provide that viewer information as you're setting up perhaps targets, especially for critical access hospitals, if we're able to get that. Now, some of the scenarios I showed were for county level in the whole state. Then we would have national benchmarks available. So and we are planning to do updates at least annually on the population health portal. So I appreciate that feedback. Well, I will turn it over to David Mark, who's an assistant professor in health informatics, graduate program director at the College of St. Scholastica here in Minnesota. And their program is the oldest health information management program in the country, and they have a variety of student programs at the baccalaureate and graduate level, and they've worked extensively with rural providers through the HIT Regional Extension Center, and they really focus on rural HIM as well. So they definitely have an interest in making this information usable for smaller hospitals. And David, you can just click on the arrows as needed to advance your slides.
All right, thank you very much, Sally, and thank you everyone for having me here this afternoon. And so today I'm going to offer you a presentation as an opener to really look at population health management and rural health, and specifically looking at ways in which claims data can be leveraged for those population health efforts. So I'll begin with just offering more of a definition of population health management. And really when we talk about population health management, what we're talking about is an endeavor to really focus more on the use of data to find ways to manage the escalating costs of treating chronic diseases, and to better support the better treatment and disease management of patients across the country. We've actually seen momentum from the government who looks at transitioning payment models from the fee for service, from more of an episodic care type payment models to pay for value, while also coordinating the care of patients. And in particular, health systems are really moving patients away from the high-cost acute settings to more appropriate lower-cost settings, including family practice, home care, and preventative medicine. And there's data to essentially show why this momentum is moving forward. This Clinical Appropriate and Cost-Effective Placement Project, which is from the Alliance from Home Health Care Quality and Innovation, they essentially did an analysis, and their report from that analysis showed that Medicare could reduce spending by $34.7 billion over a 10-year period if patient care settings were shifted from facility-based care to home and community-based care. And they also had an estimate that an additional $100 billion could be saved if care delivery were restructured to be less wasteful and more effective. So these additional reductions, they could be accomplished using bundled payments and by looking at adding policy to reduce post-acute care spending. So, providers and payers alike, whether it's in a rural or urban setting, there's powerful incentives to change with these new payment models. But to survive, they will need to assess and analyze vast amounts of population data from many different outpatient settings to examine what's working and where there's opportunity to do better. And in particular, you see the different groups and programs that need accurate data about outcomes for various patient populations. And this is really seen in patient-centered medical homes, accountable care organizations, and CMS's bundled payments for care improvements initiatives. So if we look at claims data, it's really a rich source of data that can be leveraged by healthcare organizations to examine the care of populations. In claims data, it's administrative data that is submitted by hospitals and physicians for payment and includes information on things such as patient demographics, billable charges, dates of service, diagnosis codes, procedure codes, medication refills, insurance, and providers. And claims data is submitted differently depending on whether it's a physician or a hospital that's submitting the data for payment purposes. So these are also submitted in electronic format as well. So you see CMS Form 1500, which is shown on the left side there. This is the health insurance claim form used for submitting physician and professional claims, where this UB04, which is also known as CMS 1450 form, is for facilities such as hospitals or outpatient facilities. So the data is structured differently depending on the care setting. And the CMS is actually the government entity which mandates the use of these forms. But what's actually interesting about them is that other payers require these same forms for submitting payments. So when we look at just historically, looking at payers and health systems, they historically have actually used claims data for an analysis associated with population health management. And this is due to several different attributes, and actually rural hospitals and others can leverage the data for the same reason. And the reasons are, well, first, claims data it's readily available. The requirements for payment to the providers to ensure that data is entered into the claim system on a complete and timely basis. So therefore, healthcare providers, they can leverage their own claims data for purposes beyond just submitting for payment, in this case, population health efforts. Second, claims data spans the patient's full continuum of care. So the payer has a record of every encounter and every prescription filled, unless the patient pays for services out of his or her own pocket. However, there are some limits to this full picture, as I just stated, and those limits may be that the claims data may not include a full family history or every diagnosis if they weren't part of a patient visit or it wasn't part of a claim that was submitted previously. However, claims data, if you look at it, it can be concatenated across care visits for just a single beneficiary, and you can examine an approximation of that full continuum of care. And the third reason that it has an advantage is that claims data is highly structured. So you saw those forms in the previous slide, and almost all the data that's captured for claims is entered in specific fields on these standardized forms. And in order for claims to be approved and payment to be issued, they have to abide by this standard format. And because of this consistent format, it's relatively easy for other systems to consume the data, as well as looking at data analysts who can easily query the data for purposes beyond payment submission. And this really offers an advantage over other unstructured data sources, such as clinical notes, which can be difficult to analyze without more sophisticated types of algorithms like natural language processing and so forth. Claims data can offer insights into patients and population health management, looking at health outcomes, utilization of services, and so forth. And the data derived from claims, including procedures, diagnoses, the date of visits, medications, providers, and so on. This data can be leveraged by the healthcare organizations to really gain information about the cost and utilization of a patient population across multiple care settings, as well as information about the types of diagnoses and procedures that are commonly performed. And specifically, the data from claims can provide insights into performance measures, including things such as mortality rates, looking at complications, looking at access to appropriate health services, and also charges for the care that's provided. Now, although claims data can offer organizations an opportunity to derive information regarding population health, there are numerous limitations that must be considered. First, claims data, it does lack important clinical detail. Claims data, it's designed to capture only as much detail as is required to determine payment. In this type of data, it does not capture all of the clinical details of the patient care process. So although a collection of claims that can include information about chronic conditions or history, a single claim does not include that patient history unless it's relevant to that specific treatment or procedure. So as a result of this, data critical to an accurate analysis, it may be missing from a particular claim. Also, a claim may not include all diagnoses and typically lack some of the critical data, such as lab results and a full list of medications. Claims data is also highly retrospective. There's a significant lag time between the date of the care or service and the date the claim is actually, the data is made available for analysis. And this may actually result in a lag period of months. And part of this delay is actually due to the fact that the data needs to be verified for accuracy, especially looking at the diagnostic and procedural coding, in order to have a basis of data for establishing payment. And with the speed, though, at which new discoveries in population health management and just healthcare in general are made, lag time can make it difficult to deliver an accurate and timely analysis related to population health. But with that being said, claims data does have a key advantage over traditional clinical data that you would find in your electronic health record from the perspective of completeness. It can be used to more accurately understand the total cost of care of a population and to identify patients who may not be getting a lot of their care from your facility. Another thing to understand is the limit regarding that claims data does not provide insights into the actual process of care. So the key to improving the quality of care is to understand the dynamics of the processes that are involved in the actual delivery of the care. And since the claims data is just a static summary of the diagnoses of the procedures and costs, the full care process and the effort to actually identify the root cause of any variation between care visits may be difficult to actually see. Critical access hospitals, however, are uniquely positioned to address some of these population health challenges in the communities they serve through a broad system-based approach. Critical access hospitals, they have an opportunity to understand and build the case for population health. And the way this can be achieved is to make value a priority, which is likely to be enforced through some of the value-based purchasing programs. Also, you need to identify how the community presence it can actually pay off for your organization. In administrative and executive support within a hospital, it's critical to frame those conversations and build that support for population health. Also, you need to find how data can be leveraged to support population health initiatives, including the data from claims. You also need to discuss the impact of determinants of health on population engagement, and how the people you serve, both in terms of the socioeconomic status, but also in terms of chronic conditions, technology use, and other factors can impact the care that you provide and the analyses that you need to do. Also, you need to find a way to describe population health as an opportunity and not just something that takes time and money. You need to seek examples where the population health has worked and work diligently to create your own examples. So population health also needs to be placed on the agenda within an organization, and strategies really need to be discussed across all levels of the organization, with education being a key priority, and that education being provided to staff, providers, and the broader community. And it's really important to look inside your own walls, develop ways of maintaining healthy behavior within the walls of your organization by looking at promoting wellness programs. And this really helps to get buy-in and maintain support, and also helps to implement, look at ways of implementing case management and care coordination for employees, particularly those with chronic conditions. And finally, reach out to the community. Utilize a community-based participatory approach to population health. Don't wait to engage the community and include community members in that conversation early on with expectations set early to identify the roles of your organization and how it can really play in the support of the community. And think beyond traditional healthcare partners to identify ways to coordinate efforts and collaborate. So how can critical access hospitals use claims data to support this population health management? Well, population health management by critical access hospitals, it can be evaluated using claims data, and there are many examples where this can be seen. Claims data, however, is just one data source where such efforts can be achieved. And you can do things with claims data, such as looking at which patients frequently visit an emergency department because they can't get in to see their primary care doctor, or who is being hospitalized because they can't get care at home. Or you might do things looking at conditions like asthma, where which asthma patients should be on cortisone inhalers but are not. You could look at which cardiologists are prescribing multiple stress tests, potentially to every patient, when that may not necessarily be necessary. You could look at the frequency of healthcare-associated infections. You can look at total costs of care for super utilizers and for those patients in your community, and really looking at the common diagnoses for those super utilizers, because maybe it's a specific subset of the population and you can target that subset more directly. So to access claims data, organizations have several options. Claims data can be reviewed internally, looking at your own organization's claims submissions, but there are other sources of claims data that you can explore. CMS and other payers provide aggregated claims data that can be accessed by healthcare organizations, and some of these data sets are made available to you, or they're freely available, and others you can access them through other sources, and they may require a fee for access, and at times may require something like a data use agreement. Some examples include the All-Payer Claims Database, which is an example that includes aggregated claims data for organizations and is managed and disseminated by each state. However, not all states participate in the program, so it's best to visit the All-Payer Claims Database Council, the website, to verify which states participate and see if your state is included there. MedPAR is another example, which is the Medicare Provider Analysis and Review data. However, this only includes inpatient data that is disseminated by CMS, so may not be as relevant across critical access hospitals. There are fewer critical access hospitals included here, but what's interesting about the data, it does include 100% of the Medicare beneficiaries using hospital inpatient services, yet that entire data set is not easily accessible. However, there is a limited data set that includes just a percentage of that full data, but it can be accessed for a fee. There's also the hospital outpatient prospective payment system data, which is claims level data for outpatient services that are managed by CMS, and this data set is very extensive. There is a fee to access this. However, the data elements include things such as the diagnosis code, the bill type, any outlier payments, and service revenue payments. And this data includes close to 90,000 claims for partial hospitalization program services, which are furnished by hospitals and community mental health centers that are paid under the OPPS. And finally, you have this, these RIFs, the research identifiable files, which contain beneficiary level protected health information that can be used for research purposes. It does, however, require a data use agreement, and applications are reviewed by CMS's privacy board prior to obtaining access to the data. So when should claims data be analyzed? Well, really when the data is available. Remember, there can be a lag period on when that data is available, but really claims data should be analyzed when you need to analyze a broad scope of data for insured patients that offers an accurate record of a lot of data, including prescription refills and information on current diagnoses and procedures. However, you may not get that full historical perspective. And also consider aggregation of the data and the power that can offer your organization, looking at analyzing data based off of a monthly time period or quarterly or annually to see if there's any shifts in the care that's being provided and the payments that are being placed. And also create a plan for scheduling these analyses into the future. Also, look at, in order to be effective with claims, you really need to have a strong understanding of the clinical data, including the diagnostic data, which is like ICD-10 codes, or you might be looking at ICD-9 codes, procedural codes, the CPT, HCPCS, and really having an understanding of the way of working with that data and how to interpret it. You also need some analytical skills. If you have skills using Microsoft Excel, that's excellent, and those skills can be leveraged for doing analyses of claims data. But also you should have an understanding of data summarization, creating graphs, and if you have access to more advanced software, or maybe data visualization software, that can lend you even further flexibility and power with the data. It's also important to have the strong communication skills, particularly when it comes to identifying the clear needs within your organization, including the necessary parties and communicating with them regarding those needs, and then also disseminating your findings to the relevant audience. There's also a wide variety of other sources of data that you should consider looking at, and which Sally has already described. Some of these from what we showed in the population health portal, and these include other publicly available data like the Hospital Compare. Consider looking at immunization registries and what that can offer your organization. Looking at the Department of Health data that may include a variety of different data sets within your own state. There's also nationally reported data, like for instance, there's HEDIS, which is a tool that's used by, well, anyone could look at this, and it's really meant to compare health plans. And there's a variety of different measures you can look at to compare those health plans. HCUP is another example, and that includes a large collection of longitudinal hospital care data, and is a collection of databases that could offer a lot of information, but also social media, which, you know, we tend to not think more about it other than just being there, but it is a rich source of information, and although it's messy, it can offer you a better information about the issues and trends in the populations that you serve. You could look at things like Twitter feeds, for instance, or Facebook statistics, among many other sources of social media data. So what have the national, so in an effort to really support the population health and offer greater educational support, the National Rural Health Resource Center, in cooperation with the Federal Office of Rural Health Policy, created this population health portal, as Sally previously described. And the portal is really designed to help critical access hospitals, flex coordinators, and rural health networks navigate that journey towards improved population health. And specifically relevant to the topic I'm talking about, the portal does offer tutorials on how to effectively conduct population health analytics using claims data. And there's educational modules that were built into this website that offer step-by-step instructions of common population health analytical procedures. Now, regarding those tutorials with the claims data, the portals offer access to a large publicly available educational claims data set known as DSynPuff, which is the Data Entrepreneur Synthetic Public Use File. It has a lot of background information in it about this data, how to access the data, and examples on how to analyze it. The intent is just to offer greater support for offering you ways of analyzing claims data and how to work with that data, and actually demonstrates how to carry out those methods. So just a little more information about this DSynPuff. It is a data set that was made available by CMS. It's a set of realistic claims data from 2008 to 2010, but the data is provided, it's actually scrambled data from real claims data, and it was scrambled in such a way that each claim represents a real patient scenario, but the patient's identity is secure. And the whole purpose of this data was made available by CMS for the purposes of training and around data analytics, data mining, and also development of software. So it really offers a lot of information and data that can be made available for your own purposes. It includes claims data on a variety of different levels, beneficiary summary, inpatient claims, outpatient care claims, carrier claims, prescription drug claims. And if you go to that website, the DCIN website, which the link is shown here on this slide, you can explore more information about the data and how to work with the data, but also the population health data, the population health portal includes tutorials that assist you in actually showing you how to download that data, how to work with that data, including step-by-step instructions. There's two main videos that are offered. The first video is the instructional video on to access and download the data. The second video is an example on how to utilize the claims data to carry out a population health analysis. In this case, it was looking at how to determine high outpatient utilizers and their economic impact for healthcare organizations. So there are a wide range of analyses that can be conducted with this data, and this is just an example of one such analysis. However, I highly recommend you go out there, check out this source of information to better understand how claims data can be leveraged for the purposes of population health. Claims data can offer a rich